Hello everyone. We are going on with our small lecture series. So today the topic is care beyond NICU. This is very important because we have to understand that the discharge and post-discharge planning is a continuum. So a sick baby who get admitted to NICU should be taken care by a PCP in a proper way, but the responsibility ultimately lies on the NICU team to make sure that everything is lined up because PCPs, they are very busy in their practice. So let's start. So first of all, the discharge planning start as soon as the infant is clinically stable, and this is a small checklist, and you all know about that. But just to walk you through that, infant should be maintaining the temperature in a crib, is eating orally all feeds, have completed the screenings, and all the discharge plan is done. So, for example, here is a case, a baby bird who is seen in the clinic by Dr. Docs. The baby was born at 27 week, is staying in NICU for 9 weeks, and the discharge summary is 12 pages. Imagine some of the PCPs don't have access to the electronic record which the NICU is using. They might be practicing in a different network, and they get the printout of the discharge summary, and it's really a cumbersome issue while you're seeing a baby and scrolling through 12 pages. We already have a lot of workload on our PCPs in terms of looking at our NICU graduates. So we have to make sure that we should have a summary for them. So again, they don't have time to go through 12 pages. So what we are proposing is that make sure that you highlight the problems which you really want them to see, and we'll walk you through. For example, this is the ER chart, which is here. You can fill all these gaps with these information, or just summarize it, whatever the baby is going to need. This is again an example that look how many problems listed here. Just summarize as stated in the box here, so that way they don't have to go through all that while they are in the clinic. So this is an outline for our PCPs, those who are seeing our NICU babies, that make sure that all these are follow up in a structured way. And of course, most of the PCPs do look at that anyway. The growth, the development, the hearing, vision, making sure that the babies are gaining good weight, they are following the medications which were given as the NICU discharge. So common discharge problems, some babies are sent home with gastrostomy. So the PCP just have to make sure that it's not leaking, and the surgery is following that, and appropriate plan to close it. Same thing with discharge medication. We have to make sure that they should be weaned off gradually from these, and make sure that they are going. For example, if the baby is on digoxin, they should be seeing a cardiologist. Jaundice is not a problem after a few visits, but if you are seeing a neonatal discharge after phototherapy, just make sure that bilirubin is being followed. Respiratory support, if the baby is sent home on oxygen and monitor, then it's a responsibility of PCP in making sure that a pulmonologist is following and patient is being taken care of. And of course, there are miscellaneous depending upon whatever other ancillary support the baby had. So a few words about growth and development. Make sure that you have a growth chart follow-up and a developmental screening. Most of the NICU follow-ups do have developmental specialists to look at development, and that's very important. The other thing is speech and development. Make sure that you have a speech person who is available in the clinic to follow these babies up. Then of course, hearing and vision. Usually, hearing is taken care in the NICU as a screening, but if baby fails, then the responsibility lies on the PCP shoulder to make sure that there is an audiology follow-up plan at 3 months, 6 months, as per the AAP recommendation. And of course, vision, if there is an ROP laser done or Avastin, or they have used the anti-growth AFG, you just have to make sure that is being followed up by the ophthalmologist. Same thing with the apnea monitor. Usually we don't send babies on apnea monitor. This is an old practice, and we don't do pneumograms anymore. But if the baby is sent on SAT monitor and oxygen, make sure that there is a weaning plan in hand. Again, reiterate the same thing, that we don't do pneumograms anymore, and the monitor should be discontinued. Here we mean oxygen monitor, not the apnea monitor, because we don't use it now. And again, prevention for RSV is very important. And now you guys are aware there is a new kid on the block, which is Nirsevimab, and this is only one dose as compared to Synagis, which was given every month during the season. So follow the AAP guidelines, whichever, or family practice guidelines, whichever you follow. But make sure that baby should receive RSV prophylaxis. And of course, this is the checklist. When you see the babies in clinic, make sure that they're feeding well, they're growing okay, their speech is fine, they don't have any hearing issues, and they should be weaning off the support whichever they are discharged from the NICU. And this is just a mnemonic to remember what to do. And these are our references, and we have we are on web, we are on YouTube, and we are on Insta. So do log in to check. I hope you guys have learned something together today, and you guys have a wonderful day. Bye.